So what happened with me is that I was recruited by a couple other health systems. And after about 4 or 5 years at the Level 1 Trauma Center, I started working in I started doing rural emergency medicine.
Hi, everyone. Welcome to PA-eShadowing. Just letting, alrighty, our guest, Professor Van Heck. All right, let me let him in, guys. Okay, here we go. Hi.
Hi, good evening.
Good evening. How are you?
I'm doing well, and yourself?
I'm good. Thank you so much for coming on.
Absolutely. Can you hear me okay? Can you see me okay?
Yes.
Great.
Dr. Van Heck?
Just Van Heck.
Okay, Van Heck. Thank you so much.
Yeah.
Thank you again for coming on, guys. We have Professor Eric Van Heck. He is also an emergency medicine PA. He's been in emergency medicine for quite some time now, I think a decade now.
Yeah, about 12 years. I graduated from PA school in 2009.
Yes, wow, that's when I graduated from high school. Wow, so that's a long time, guys. He has a lot of experience and knowledge to share with all of us, so excited to have him.
Yeah, I'm happy to be here. Thank you so much for the opportunity.
Thank you. Someone said he looks young.
Well, that's very kind.
All right, Eric, so we always start with just sharing your pre-PA journey, why you chose PA, what made you go into the PA field, and how you got your patient care hours and ended up getting into PA school.
Yeah, well, thank you. It's a great question. I'll try to keep the response as concise as I can in the interest of time. What I think is interesting about when I think about my pre-PA journey, and certainly I think for the case of many PAs who entered in the PA school around the same time that I did, is, to be honest with you, we were a bunch of people who didn't really know about the profession, heard about it, and then applied and somehow got in. To be honest, we were probably all mostly pre-med people who didn't get into medical school for one reason or the other, and it ended up being the best of circumstances.
Right.
That the outcome was that we became PAs rather than physicians, and that's not at all a criticism to my physician colleagues, but just more so that I think that all of us who ended up becoming PAs were really influential with respect to shaping the profession sort of in its earlier years to what it potentially is and still can be now. So I did my undergraduate studies at North Dakota State University in Fargo, North Dakota. Long story as to how I ended up there, which really isn't necessarily so relevant to this discussion. But nonetheless, I went to NDSU. I was a pre-med focus, but I was a zoology major, which is to say that if you were pre-med and didn't want to take botany, you were a zoology major. So you wouldn't have to stand in that line, and that's where we all ended up. So at the same time, I knew that I wanted a career in medicine. So a majority of my pre-professional or healthcare experience hours, I was a phlebotomist at a clinical research, a pharmaceutical research facility in Fargo. And I worked there, I would say I worked there for about 20 hours a week for at least 2.5 years. I also, one summer between actually it was 2 spring breaks consecutively. I also completed my EMT basic and did some hours with Fargo Moorhead Ambulance, did some stuff with them as well as part of my health patient care hours. Finally, I was also in the shortly after 9/11, I joined the United States military.
Yeah.
So I did some things with the Army as well. I was an infantry officer for a while, and then during PA school and after PA school transitioned and became a medical officer. More specifically, in the Army, you're in the medical specialist corps. And then immediately after graduation, after my PA graduation, I did a deployment as a PA. Yeah.
Yeah. When I was reading your bio, I read that, your first job out of school was
Correct.
in
Correct.
Iraq,
Yeah,
right?
that's
Yeah.
correct.
First of all, thank you so much for your
Yeah,
service
of course. Of
time.
course.
That's very commendable, and especially going to Iraq and
Yeah.
during that time, 2009 or 2011. I'm guessing it was you finished with PA school. So how was it? I mean, I'm sure you're a new grad. You're in a foreign country,
Right.
How what motivated you to do that or to
Yeah. Well, that's a great question. So, throughout my undergraduate journey, a few things happened. I was concerned about the financial burden that I was taking on at the time of undergrad. In addition to that, shortly following 9/11, I felt this calling to serve my country. And so during that year is when I enlisted. And I was able to still complete my undergraduate studies on a relatively consistent timeline. I was able to do some split training options, and then continue on. So it was. I'm no longer in the military. I've been separated from the military for a few years now. But what I will say is that it was for me, and I can't say the same. I mean, the military is great. Is it for everybody? No, not necessarily. But for me, there are still things today that I lean on that I learned in the military. I think that a lot of I think it really helped shape my leadership, which I utilize all of the time, whether I'm working in the emergency department or I'm in my academic setting at Augsburg University. I really lean on some of those leadership skills that I learned throughout the military. But one thing that I didn't mention about your first question is that I think a lot. So what happened? I applied to medical school. I did a couple of times through, and I was always somewhere middle of the road on the wait list. I had in a very honest way, I had a very mediocre MCAT score. I did some poor planning during undergrad. This is back when you could only take the MCAT 2 times per year. It was still written, so you could only take it in the spring or in the summer. Yeah. And what I did, unfortunately, looking back on it, I did not spend enough. I scheduled it during a pretty demanding semester, and I essentially had to make a choice. Do I want to focus on the courses that I was taking and still maintain a good GPA, or do I want to spend some time and maybe sacrifice a bit of a GPA for studying for the MCAT? Well, I chose the former rather than the latter. And as expected, I performed rather mediocre. And I knew that was ultimately what was holding me back. So after a few years being out of undergrad, I was again working for a different pharmaceutical research company, and I had the chance to work with a PA. And she really shaped my desire to become a PA. I remember several conversations that she was willing to have with me. And I explained that ultimately my career goal is direct patient care. That's what I'm interested in doing. And she said, "Hey, idiot, why don't you apply to PA school? That's what we do. That's our entire profession is direct patient care." I said, "That sounds amazing." So I applied to PA school, and I said, I'm going to apply to one. I made it, what I came up with in my head was to apply for one application cycle. And if I get in, then I'm going to go. Otherwise, if I don't get in, I'll buckle down and study again for the MCAT and see what happens. So fortunately, I said, I did something. I convinced someone that I should be deserving of a seat. And I was given a seat at Augsburg University. And in 2006, I started, and the rest is history.
Wow. Yeah. Great. So, how was your time in Iraq? Especially as a new grad, because you had medicine, and then you had to,
right.
Was that your first time in Iraq?
My second, actually. So my first time, I was, here's what I would say. Obviously, just like anybody else who deploys, from a personal standpoint, it's always going to be very challenging. Mm-hmm. From a professional standpoint, I would argue it was probably one of the better things or more helpful things I could have done professionally. I had this, don't get me wrong. I mean, there was numerous challenges that I had to work through. But I was in I was in a medical unit. I was paired with another PA who was 5 years my senior. He's been practicing for 5 years, and it was fantastic he's my easily one of my best friends, still to this day. And this was this wonderful opportunity to there was nothing else for me to do other than to see soldiers as patients, to study. That was pretty much it. That's all that I did. So effectively, it felt to me almost like an emergency medicine residency is what it felt like.
Okay.
And I really felt, after leaving there and coming back to the Twin Cities area and then working in the private sector, that I had some skills to walk into a level 1 trauma center and be able to perform, be able to manage patients and do it well. So yeah, so it was sort of this juxtaposition between a very challenging time, but yet a very professionally fulfilling time.
Right. And how long were you there for?
A year.
A year. Okay. Oh, that's not bad.
Yeah.
So when you moved back to the States, I'm sure it was easier to get a job. Okay.
Sure.
Yeah. And I read that you worked in various like level 1 trauma centers. As you said, you got that great experience. So
Right.
What was the difference between like, your job in Iraq and then like going to the States and working, was it level 1 trauma right when you just came back into the US? Okay.
Yeah,
So how was that?
So when I finished PA school, we had at the time, the way that our clinical rotations were organized, our final clinical rotation was actually twice as long as the other rotations. And we did it in some area of primary care, whether that was family medicine, pediatrics, emergency medicine, outpatient internal medicine. And I had the opportunity to do it at a level 1 trauma center in St. Paul, Minnesota, called Regions Hospital.
Okay.
And effectively, what it became was more or less, it was almost like a 12-week interview. At least that's how I approached it. And in a very flattering way, at the end of it, they offered me a position. But in good faith, I knew that I was going to be deployed.
Yeah.
And so I ultimately turned down that initial offer, knowing that I was going to be deployed. And they were willing to at least say, hey, if there's a opportunity when you're done with your deployment to come back, we'd love to have you. So as luck would have it, there was a chance for me to go back.
Yeah.
And so I started at Regions. And what I will say is that Regions was coming off of the deployment. Regions actually was more challenging than I expected. One of the things about practicing, medicine in a forward deployed environment is, generally speaking, the soldiers that you're managing are all healthy individuals at baseline.
Yeah.
So really what I was very comfortable with is managing trauma. What I wasn't so great at managing at the end of the deployment was complex medical cases.
Yeah.
You're a patient with a complex medical history, for example, managing a patient who might be an older patient with a history of end-stage kidney disease, who is dialysis dependent, who also has a history of atrial fibrillation, congestive heart failure, and COPD, and type 2 diabetes mellitus, and they're coming in with right, exactly. So it took a while to develop that skill set, to be able to be comfortable with managing these complex patients who and managing critical care. Fortunately, I had a wonderful set of attending physicians, and also it was an academic center, meaning that they also trained MD residents who are becoming, board certified in emergency medicine. And I took every opportunity to listen and learn wherever I possibly could.
Yeah.
And they were more than willing to share, that education, to share that knowledge, and really help develop me as a PA into the type of emergency medicine provider that I wanted to be. So on one hand, very comfortable with trauma. On the other hand, probably still looked pretty foolish with respect to managing, complex patients, medical patients.
I beg to differ after 12 years.
So
I'm comfortable with anything now.
Yeah. Now it's much different. But back then, I would say that was the big difference, especially in the first year. Sure. Yeah.
So I know we fast forward a little bit to talking about your career, jumping right into that. But I want to know a little bit more about your experience in PA school.
Sure.
To give the students more insight on how that was like. How was it being a PA student, especially that first semester, and having to kind of shift your studying, shift your whole life, and really I guess basically sacrifice everything for school. So
sure. It was challenging, but it's not impossible. And I guess it's hard to, I know that here's what else. I was probably a very mediocre academic student throughout PA school. I was the type of student that really, I think, blossomed and understood and came into my own during clinical rotations. Mm-hmm. When I think of medical education just in general, whether it is medical school, PA school, if you're becoming a nurse practitioner, I really think that there's two systems. There's a system of medical knowledge, and then there's a system of medical practice. And I will be in a very honest way, I will happily admit that I am not the most knowledgeable medical provider out there. That is not where I think that my skill set lies. I think that I work really hard at practicing medicine really well. Yeah. I really enjoy all of the other things that are so important to practice medicine. Right. I enjoy the human side of medicine. I enjoy the emotional intelligence that's required. I enjoy the vulnerability. I enjoy the validation. I enjoy setting boundaries. I enjoy being really, really empathetic within those boundaries. So I think that knowing that, during the academic side of things, that knowing that it's the academic side, it's all primarily within the system of medical knowledge, perhaps I struggled. And where I think that I struggled is that I didn't have any great frameworks in place. And what I would say is my first piece of advice to anybody who's starting medical school is you have to have some sort of frameworks. Frameworks are one of the most important things, I think, ever in anything that we do. Yeah. Is having some sort of framework. So number one, I think that having a framework, knowing how to study. Yeah. Doesn't matter what it is, but understanding how to study is going to be important. Understanding how to study efficiently is incredibly important. And then also having boundaries around your studying. Make no mistake, there is a law of diminishing returns. At a certain point, you are going to reach a saturation level where beyond that point, your retention and recall of any sort of material is not going to lend itself to the amount of time. It's not a linear curve. It's more of like a logarithm or an exponential curve. There's a curve to it. And I think that one of the things that I see for students is that they're afraid to put things down. And they're afraid to allow themselves the space outside of academics. And what I would argue is that unapologetically putting things down, fulfilling yourself with still the things that make you you, giving back and nurturing the relationships that still feed you, will make that intentional time that you put back to academics better. And I wish that I would have known that when I went into PA school, especially when I was going through the academic side. Mm-hmm. Frameworks, knowing how to study, understanding intentionality with my study, understanding boundaries with my study, I think would have been a lot better. Needless to say, though, I progressed through, okay. I did just fine. I progressed. I passed PA school. I passed, the PANCE exam. So all of that, but I think that if I had to do it all over again, knowing what I know now, those would be things that I would do differently.
Got it. Thank you. And thank you for providing that advice. And I hope
Yeah.
you all are listening. So was emergency medicine your favorite rotation?
Yes. However, when I started PA school, I thought I wanted to do a surgical specialty. And I did. I had just the way that my rotations sort of fell into place. I did general surgery, and then I did it in my elective, which was plastic surgery. And surgical specialties are wonderful. It just wasn't for me. And what I think that I was missing, and this is not ubiquitous to all surgical specialties. I'm not trying to paint surgical specialties in or make any sort of generalizations. By and large, what I found frustrating was that I didn't spend a lot of time with patients and their families interacting and explaining what was happening. For me, it felt very binary, very cut and dry, very black and white. And I prefer the grayness of medicine. I like the complexity I like the social complexities that come with every patient encounter, because I think that's what makes this job interesting and unique and fun and challenging. And I sort of lacked that when I was in the surgical specialties, and I found it in emergency medicine. What in my opinion, and again, of course, I'm biased because I've been practicing emergency medicine, for 13 years, is that I would argue that emergency medicine as a specialty is the most human of all specialties. We see people in their absolute most vulnerable and raw state.
Yeah.
And that's what I really enjoy about it. I enjoy the responsibility of being able to be there and to tell a patient or their family on their worst day that, hey, I got you. It's going to be okay. I got this.
Yeah.
I got this. Your family member's going to be all right. This is what's happening. Here's what to expect. Here's what we're going to do. There's something about the intensity of those relationships that I really like, even though they're very short-lived. And yeah, that's what makes me want to get up and do it 13 years later.
Awesome. So I've never worked at a level 1 trauma center. The highest I've worked at was level 2 in New York. But can you walk us through a day in the life of an emergency medicine, level 1 trauma,
sure.
PA, because that's a very, very intense environment. So can you?
Yeah, I'd be happy to. Well, let me start by I have students who come into my office all of the time and tell me that they want a career in emergency medicine. And what I tell them is that it depends on what the individual student is looking for out of their emergency medicine career. So I'll draw a comparison. So there are 3 level 1 trauma centers in the Twin Cities area.
Okay.
I worked at one of them, and the other 2 utilize PAs a bit differently than the one that I worked at. Sure. And what I will say to students who are interested in emergency medicine is investigate the process on how PAs are utilized in any ER that you're applying to.
Very, very true.
Yeah.
Fast track and just leave you in fast track.
That's exactly right. Because things are unique. So for my situation, I was brought into the Regents Hospital. And as I mentioned, it was an academic center. My job was to ease the burden on the attending physicians and the residents so that they could actively learn during shifts. And my job wasn't necessarily to learn while I was there, even though I did. I found ways to be sneaky. But my job, make no mistake, was to ease that burden. My job was to see patients and see patients and see patients and see patients. And that's great. I mean, that's but they gave me the opportunity to do it in all areas of that emergency department. Once I established trust with the attendings, that I could manage critical care patients, whether that was trauma patients or medical patients, once I sort of gained some of that skill set, then I was able to really, do what the entire scope of that specialty was available to me. Some other level 1 trauma centers don't utilize PAs that way. Just to your point, they utilize PAs in the quick track areas where you're pulling off the lower acuity patients, whether that's a level 4 or level 5. And for you students out there, level 1 is the highest acuity, level 5 is the lowest acuity. And so something that's a level 5 or a level 4 is any real urgent care type patient.
Right.
So there are a lot of PAs are utilized for that skill set where they don't need a lot of supervision, where they can see a bunch of these patients, ease the burden of the department, ease throughput times, and do great work. So that's kind of the scope of most level 1 trauma centers, whether or not, where you're at with those things. Now, in my career, what happened is there's a funny thing that happens when you graduate and you work a few years in a specialty. If you make your reputation on A, showing up when you're supposed to show up, B, working hard while you're there, and C, seeming like you enjoy it and you're enjoyable to be around, what you realize is that how small the PA community actually is in your particular geographical location. And then after time, when you make your reputation on those things, people start calling you and they say, hey, come work for me in my health system, more money, less time. And then what are you supposed to say to that? Anybody's going to say yes to that. Who wouldn't say yes to more money, less time? So what happened with me is that I was recruited by a couple other health systems. And after about 4 or 5 years at the level 1 trauma center, I started working in I started doing rural emergency medicine. So I worked in rural emergency medicine where it was what we call double coverage. It was actually a level 2 trauma center. So I'm working alongside it was just myself and one other physician at a time. And oftentimes we were almost like 2 shifts in the night. We would sort of like see the same patients, collaborate occasionally, both back and forth, but really sort of like working together. Now, of course, there's still my supervising physician at the time, and that relationship is still there, and I'm respecting that relationship. But that's kind of how that went. So I did that for about 3 years, and then actually Regents called me back again. And then I went back there for another year, worked there again, sort of helped a little bit develop their PA emergency medicine residency program. And then another health group called me and said, hey, we have this really unique opportunity where we staff. So in Minnesota, they have what's called critical access hospitals. Right. These are hospitals that dot rural Minnesota. And they're there Minnesota has a state statute where they want a hospital facility within a certain geographical area. But generally, these are pretty small communities. So from an economic standpoint, it makes more sense to staff them with PAs than it does physicians, because physicians are expensive. So for the last 5 years, I've been working exclusively for a group that staffs local critical access hospitals where I'm the sole provider there.
Yeah.
Oftentimes, yeah. So I've been, right? Nope. I run the show. I run the department. I run my, my nursing team. There's sometimes when we admit patients there's a hospitalist that's there during the day, but I provide cross cover on the admitted patients in the evening. And I've been doing that now since 2015. And I love it. I love it because it really allows me the opportunity to really kind of get in and do the things that I love to do, which is interact with patients on my timeline.
Right.
And I love that.
Yeah. I guess my question is now, like, how was it then doing that and getting comfortable, practicing like completely just on your own? No, because it's kind of like urgent care, or you're on your own, but it's actually the ER, anything can happen. So How did you feel getting into that and getting comfortable? Did they provide any support initially?
Well, not really. So of course, I mean, I'm partnered with a supervising physician.
Right.
And there's always like the ability to contact that supervising physician if I was to ever have a question. But for me, after working there since 2015, after 7 years, wow. I haven't called my supervising physician once, because for me, at the end of the day, if I have a clinical question, I'm going to call a hospital where I'm going to transfer the patient to and have that discussion with whomever is going to assume care to help provide specific guidance. But here's what I'll say. I mean, single coverage work is unique. Single coverage work it does take a little while to be comfortable. I'm not sure that, I mean, there's always going to be, I have a list of a few things that I don't want to say keep me up at night. That seems a bit extreme. But of course, there's always going to be a particular patient when I think about the management of that patient, that algorithm makes me nervous. Of course. But fortunately, those things happen to be pretty rare. So what I think is that over time, you develop a confidence in your own skill set. Here's what I'll say. You have to want to learn critical care medicine, at least where in the paradigm where emergency medicine and critical medicine overlap. You have to want that skill set. Not everybody does. And there's absolutely nothing wrong with that. Nothing wrong with that whatsoever. But for me, it was a challenge that I wanted. I think that it spoke to a lot of my personality with respect to my want to be able to sort of have my interactions sometimes when you work in these big health systems, there's all sorts of metrics, throughput times, et cetera, provider to patient times. And I wanted to be able to have some control and some buy-in and some say on those things. And this was an environment that let me do it. Also, I wanted an opportunity for me to really be able to utilize my leadership skills. And there's no better place than to be a leader. Every day you show up there, you're the leader. That's the way that it is. And so I like that. I like the responsibility of having to earn my support staff's trust. And make no mistake, that's the way that flows. I didn't show up there and expect them to impress me. It was the other way around. It's my job to establish trust with them. And I really enjoyed that. I have enjoyed that. I still enjoy that. I do that every day. It's never done. It's always a continuation.
Perfect. Thank you so much for that. So a student wants to know, how do PAs provide affordable care in all dynamics and clinical settings? Are they able to influence the affordability of their care that they provide?
That's a wonderful question. There's a lot of layers to that question from an economic standpoint. Here's what I will say. I mean, there are a lot of challenges that we have in our country with the healthcare delivery. And rather than go way down into that particular rabbit hole or have that discussion, because here's also what I'm going to say, that there's also some really, really wonderful, great things about the way that we provide healthcare in this country too. There's nowhere in the world after spending a lot of time in other places where I would rather have healthcare for myself or my family than still in the United States. That said, though, what I really think is a unique opportunity is the way that PAs, particularly in primary care, have an opportunity here to really own primary care in all specialties, whether that's family medicine, pediatrics, internal medicine, emergency medicine. The economics of how we do that are advantageous to us. And as long as we continue to do that and recognize that, I think that we're always going to be in demand. What's great for all of you who are listening is that, and this is, I have no data here to support this. This is just my own personal sort of belief, is that you're getting into a profession where likely through the duration of your career is still going to see upward linear growth. And that is because this profession is still very much in its infancy. This profession started in the mid 70s.
Yeah.
I mean, to be honest, we haven't been around for 50 years yet.
Right.
And I think for the first 50 years, what we've really done and really focused on for the first 50 years is we've really tried to establish ourselves to have a seat at the table.
Exactly.
We've worked really hard on saying that what we can provide is worthwhile. But now that we've done that, I think that what we get to do is we get to make our own mark in a particular way. And here's where I think we do. Nobody provides more empathy-forward patient care than PAs. Nobody. That's what we do, and that's what we will do better. And I believe that, I'm sure everyone on this call has heard of things like a nursing model of medicine, a medical model of medicine. There really isn't a PA model of medicine yet. But I really believe that in the future, the PA model of medicine is going to be empathy-forward medicine.
Right. Thank you.
Yeah.
The next question basically goes in line with the day in the life. She wants to know what are some procedures you do as a I could answer it, but as a trauma PA, can you walk us through? She answered a lot of it already, like central line, test tubes, intubation. So
absolutely.
So this was just also a good time to walk us through, I guess, a patient case study or how you would present.
I'd love to. So where I work, because it's a rural setting, generally I live in the Twin Cities area, so I travel about an hour and a half to the hospitals that I staff.
Oh my gosh!
And I staff more than one.
Times a week? Is it 3 times a week?
Not quite. So what I do is we work 12-hour shifts or more often, actually, we work 24-hour shifts because it makes it advantageous and it makes it worthwhile to drive, to have that sort of commute.
Yeah.
And I know a lot of you are probably asking, how do you work a 24-hour shift? Are you awake the entire time? The answer to that question is sometimes. But here's what I will say. If I'm not actively seeing a patient, then I'm actively trying to rest, is what I'm trying to do. Our shifts are usually 7 in the morning to 7 in the evening, or 7A to 7A. A particular day in the life would be I arrive at a little before 7. I relieve my other colleague. If there's any patients that colleague is in the middle of that patient's workup, that colleague and I will go into that room and we'll do like a formal sign-up. The colleague who is leaving will introduce me to the patient. We'll discuss the patient case a bit, discuss what the plan is moving forward, and then I will assume care of that patient. Outside of that, then I just manage patients as they come in, whether they're coming in through triage or they're coming in off of the ambulance. And as any emergency department goes, I'll manage anything that walks in. So with respect to procedures, it is I'm credentialed and proficient at doing the entire gamut of emergency medicine procedures. The thing about emergency medicine is that you have to enjoy procedures. You have to want to be a proceduralist in order to do that. So everything from as complex as central venous access to placing an arterial line, intubating, managing complex cardiac arrest, managing trauma codes where you're doing chest tubes, fracture reduction, dislocation reduction, procedural sedation, and then all the way to the other end where laceration repair, abscess incision and drainage, splinting are all easily within our repertoire.
So can you just walk us through like a scenario? Yeah.
Sure, of course. So one of the last shifts that I had was I remember I managed a 20-month-old female who was no previous diagnosed medical history, that presented through triage with her mother for evaluation of shortness of breath. And this was I trust my nurses, and I trust that when the triage process from start to finish before I enter a room can be anywhere between 10 to maybe 15 minutes. But my nurse called me into the room and said, "Hey, Eric, can you come and evaluate this patient with me while I triage the patient?" which signals to me that my nurse is not comfortable with the way that this patient looks. So I entered the room with my nurse, and we started the initial process together. Now, some background on this patient. I generally try to do a little bit of homework on the patient before I walk in the room. This child was a full-term infant, had no issues during delivery, spent no time on a ventilator, no time in the NICU, really has had an unremarkable history, has never been hospitalized, is fully immunized, including has received the COVID-19 immunization. Otherwise a pretty healthy child. But when I walk into the room, the child is breathing quite fast. Some kids tend to breathe fast at baseline due to their high metabolic rate, but this child was breathing very much above what I would consider to be normal. In addition to that, the child had what we call some increased work of breathing. So the child was utilizing other muscles and other mechanics to assist her breathing. What that tells me as a clinician is that there's a process going on here that's a bit more concerning, and that also this child is really using a lot of their metabolic activity to power their muscles in order to breathe. What I get concerned about is that while the patient might be compensating and doing well now, that may not last very long. And when that child is no longer has the metabolic reserve to continue to power those mechanics to breathe, we're really, really in a challenging situation. So as a clinician, what we try to do is we want to try to intervene as early as possible to assist that, to reduce that metabolic rate, and to start managing what was going on from a causative standpoint. So I had the mom describe how long this was going on. I take a history. I asked when she first noticed this, what else was going on. And she mentioned to me that this child's had about a 2-day history of a cough. And the cough, and she described the cough as this characteristic cough where there was sort of like this high-pitched sound at the end. There would be like a coughing episode where the kid would cough, 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 and then there would be this sort of pitch to it as well. And also, she also sort of described it as being sort of a barking kind of cough. So that sort of clued me in a little bit diagnostically. She was using some diagnostic pathognomonic words, and then also had an absence of other things. The cough was not productive, meaning the child was not coughing up mucus. The child probably had a fever, but it was a lower fever. And there were really not many other things going on with respect to the history. The child still looked okay. So what we did, we started some therapies on this child. One of the things that I did is I provided the child with a nebulizer. I gave this child actually a racemic epinephrine nebulizer, and then also gave this child a shot of a corticosteroid. And then we also did a workup. I did a chest X-ray, and I did some viral swabs. I certainly swabbed the child for COVID, despite that the child didn't have any COVID exposure and had been immunized. We did some other viral swabs, something called respiratory syncytial virus, even though it's really out of like the seasonal time frame, we also did an influenza swab too. And so essentially the workup came back negative. All of those viral swabs were negative, and the chest X-ray also looked okay too. So my diagnosis for this child was that this child was experiencing something which we call croup. Croup is sort of like this upper airway viral virus that you can have, which causes some airway sort of edema. And the racemic epi actually kind of helps get away that edema, initially, and then the steroids actually kind of help fight that long term. So after the racemic epi, the child looked really great, was breathing, their increased work of breathing went down, and the child was ultimately able to go home, which was good. So the child had close follow-up, really good return instructions, and I ended up working 2 shifts in a row. So I called the mom the next day, and the child was doing well. Yeah.
Awesome. Thank you so much. Thank you for that. So glad you guys got to get an understanding of emergent, it's truly emergent, because the baby could have declined rapidly, but how he handled it. So thank you, Eric. So before we have a few minutes left, but I wanted to touch now on your academics, going into academia, and clinical professor.
Sure.
So what made you want to do this? And do you still work, or how do you balance like work and academic?
Yeah, of course, of course. Toward the end of PA school, I had the opportunity to engage in a mentorship relationship with another PA, and he was a very experienced PA. He had been practicing for quite some time. And I remember, I can't tell you much about the interactions that I had with him, but I can tell you this. One of the things that when he agreed to establish this mentorship relationship with me, he was very direct with that. It wasn't free, that it came with a cost. And the cost of his mentorship was that I had to pay it forward. When I was a PA, that I had to pay it forward to whomever. And that statement stuck with me. And what I would say is when I was deployed, I think it started there. So when I was deployed as part of that medical unit, I had an entire platoon full of medics that I was responsible for training to help in our military hospital. And I really enjoyed that part of the deployment. And what I noticed is, even after the deployment, when I was working at Regions or any of the other hospitals, whenever I had the opportunity to have a PA student with me, I always looked forward to those shifts. I liked it. I liked the excitement and earnestness and passion that all of these students came with, and their desire to really want to learn how to do this. And so I think that during those shifts, I enjoyed them hopefully just as much, if not more, than the students did. And then, so I knew there was one day that I was giving feedback to a student at the end of one of our shifts together, and my attending physician for that shift was in the workroom doing other things. Afterwards, after I had given the student feedback and the student left, my attending said to me, she said, "Eric, there's not a lot of people who invest as much time during the shift and can give the type of feedback that you have. You have a real talent for teaching." And that was the first time that someone had actually mentioned that to me. I said, wow, maybe I could do this a bit more. So then I contacted the local PA schools. We have a few here in the Twin Cities area, and I started doing some guest lecturing, and I started doing grading self notes and doing other things, all the while sort of knowing that, or all the while sort of confirming that teaching is something that I really, really had a passion about. About 4 years ago, there was an opportunity for me to go back to the same PA school that I graduated from as a professor. And they, again, in a very flattering way, offered me a position. And I started as a half-time position. And what was interesting is, so I was doing half-time at Augsburg. I was doing full-time with one PA group, and I was doing locum hours with another PA group. It was a lot. And on Sundays, my wife and I she's an attorney, and she's very busy, has a very successful career. And on Sundays, we sort of meet to discuss like what our next week looks like. Mm. And she would ask me the shifts that I work. And for some reason, I would never include my work at Augsburg teaching as work. Mm. And then she pointed that out, and she said, you never ever mentioned to me that Augsburg is work to you. And I said, you're right. And it just so happened around that same time, there was an opportunity for me to be full-time at Augsburg. And so I took that. And so I've been full-time. I've been a full-time professor at Augsburg now for about 2.5 years. Okay. My role is primarily in the academic side. I am the Director of Student Affairs for our program. I chair several courses, or I'm the chair of the pharmacology course. And I also chair the history and physical exam course. I chair our clinical phase transition course. I chair a research course. I've developed our bedside ultrasound program, and I love it. It's wonderful. I can go on and on about how much I enjoy teaching. It's the most being able to bear witness to people who come in. But the first day of the program is my favorite day of the year. The excitement, the it's wonderful.
Yeah.
And that there's 33 students who really want to do this in a very challenging time to practice medicine. All of you should be very commended for wanting to run into medicine at a very challenging time. And to be able to kind of help shape that experience and shape those things is a responsibility that I feel humbled that I get a chance to do, and very proud of it. And it's incredible. It's incredible. I'm the luckiest guy in the whole world that I'm going to go and talk to 33 students and they're going to listen to me.
Mm-hmm.
It's great. So, but to also parlay that, so I also still practice emergency medicine. I practice about, depends on the month, but a minimum of 36 hours a month, probably a maximum of about 60 hours a month.
Oh my gosh. So
yeah.
60, okay, that's not too bad. 36,
yep.
Okay. That's not too terrible, but
right.
it still can be a lot with, teaching full time.
Right.
Okay, that's not bad. But you're also in school. You're also getting your doctorate.
Correct. I'm working on my doctorate currently. Yes, correct. Yeah.
Wow. And that's online, right? So
That's right. Yeah. So I am part of the doctorate of medical science program. That's through the Arizona School of Health Science.
Okay.
And A.T. Still University. Okay. It's a 2-year or a 3-year program. They have several different areas or concentrations, whether it's education or a clinical setting or leadership. I pick leadership just because I see like it's works kind of in any setting. My main motivation to do that is I'd like this skill set I'd like to understand more of the complexities of medical administration, academic administration, a better understanding of the skill set on how to really perform clinical research, how to publish clinical research. Yeah, so that was my motivation to pursue that part of that endeavor. Yeah.
Awesome. And then you also have the highest, it's not necessarily a degree, but certificate for emergency medicine, the CAQ.
Yep.
Yeah. So can you explain really quick to the students what that means?
I'd be happy to. So when all of you get into PA school and complete PA school, you'll sit for the PANCE exam. The PANCE is the PA National Certification Exam. Essentially, your time in PA school is to train you in primary care, essentially family medicine. And when you take that exam and then the subsequent recertification exams, you're essentially saying, I am board certified in primary care family medicine. Now, as you all know, PAs practice in every single specialty, even though they're certified in that. There are several different specialties where you can go back, and you don't have to do this, but there are several specialties, emergency medicine included, that after a certain amount of time in practice in that particular specialty, you can take an additional exam to give you a second essential board certification in that area. So my CAQ is in emergency medicine. So think of it sort of as a second kind of board certification in a different area.
Yeah, so he's basically like an expert in emergency medicine.
Not every day, believe me. I am humbled by something every single shift. For sure.
Yeah, and that's what I really liked about emergency medicine and why I went into it, because you never stop learning. Like, you never know what you're gonna get, and
Absolutely.
It's just always a learning opportunity, and it can just be really fun if you enjoy learning and that knowledge that you get from working in ER. So, and it doesn't matter how long you've been practicing. Like at him, he's very seasoned, but you still learn something new every day. Every single
shift from whether it's from my patients, my nursing staff, any support staff, my medics. I'm humbled every single shift that I work.
Thank you so much, Eric. So it's about time to go. So before I let the guests leave, before we end the session, I always ask the guests one takeaway. What's one piece of advice, one last thing you'd want the students to know before you go? Any advice, anything for them to remember as they journey along? Just what would you want them to?
I'd be happy to. So I think that there I mentioned one, but I'm going to give you the other. So I think that in life, I think that there is two keys to success in life. The first one is not easy for people, and it's vulnerability. I think that all of our vulnerabilities is A, what unites all of us, and B is what makes us stronger. Don't be afraid. I mean, and I'm saying this as if it's easy for me to be vulnerable, and I promise all of you that I've had to work on being vulnerable. I think that maybe we're conditioned to almost think that vulnerability is something that we shouldn't be doing, that it's a weakness or it shows something that you don't want to. I disagree with that. I think that there are appropriate ways. There's a difference between vulnerability and oversharing.
Yeah.
But I think that there are ways for us all to be appropriately vulnerable. And I think when we do that at the appropriate times, that's when we really, really make the biggest connection. And connection is the first secret to success. The second is frameworks.
Yeah.
When you've all sat through a lecture, doesn't matter what it was, and you didn't understand, you were like, I have no idea what that's about. And maybe you went online, you went to YouTube, and you found someone explain something you heard them explain it in a different way. Remember that moment when you felt like you understood it and you felt really empowered by that understanding? That is the power through frameworks. Whether you can create frameworks, if you can create a framework where there isn't one, that's money in the bank. That is not just money in the bank. I don't mean it economically, but also like emotionally. That's a very powerful thing.
Yeah.
Connection, vulnerability, and frameworks. That's the key to success. And if I had one piece of advice for all of you, do not be afraid to express vulnerability in your applications. I review a lot of PA applications. It's okay for you to express vulnerability. Again, you can cross a boundary and overshare, but it is okay to be vulnerable. I am looking for vulnerability. Because I know that as a candidate that knows who they are. Yeah. That's what's going to make great PAs.
Yeah, thank you so much for that. That was gems, guys. He just gave you a little key to getting into his PA program. So you better take that and run with it. Thank you so much, Eric. This was a phenomenal session.
It was my pleasure. It's my pleasure.
Thank you. It was great learning about you, the work that you do. Like, you're getting tons of love. Oh, I didn't even know you did that.
You're all so sweet.
Yes.
You're so sweet. If there's any follow-up questions or anything I can do for you or this organization in the future, please reach out. I'm happy to donate any of my time.
And it's Augsburg. Can you spell it? Because a student asked. Augsburg.
Absolutely. It's Augsburg is AUGSBURG. Augsburg University.
Okay. Got it. Thank you so much. You're getting tons of love. I will be applying in 2024. Awesome. Beautiful description about vulnerability. Thank you so much, guys. So we'll see you all next Monday with another guest. So thank you again, Eric. Have a wonderful week.
Take care.
Thank you for all that you do at the PA.
Thank you. Same to you. Appreciate it.
Okay. Bye, guys.